often people think it has to be to the tip to cause a problem. And so that's one of
Okay.
the biggest ones. If they can stick their tongue out, they're fine. It's like, well, like it kind of comes a little bit out, but it should go most of the way down the chin. But that's the worst test. The best test is elevating or lifting up the tongue, because that's the critical movement for nursing, bottle feeding, speech, eating, sleeping. Your tongue has to go up, not sticking out.
Welcome to Caring for Both, a curbside consult series by the American Association of Pro-Life Obstetricians and Gynecologists, APLOG. On this podcast, we bring on experts to provide insight to support medical professionals in their life-affirming practice and careers. I'm Dr. Susan Bain. I'm a board-certified obstetrician and gynecologist, as well as a board member of APLOG. I'm excited to be hosting today's episode. I'm also excited to announce that this episode will be the first in a regular series on our podcast about postpartum care. So from now on, we'll plan to regularly post episodes covering insights to help medical professionals offer care to our postpartum patients. The first postpartum care episode is going to be an interesting one. We have on Dr. Richard Baxter. Dr. Baxter is an Alabama-based board-certified pediatric dentist who is also the founder and owner of the Alabama Tongue Tie Center, a nationally sought-after dental practice that specializes in diagnosing and treating tongue ties and lip ties. So he's here today to speak to us about this condition, tongue ties. Thanks so much for joining us today, Dr. Baxter.
Thank you so much for having me. Excited.
Yeah, so we met about a month ago at a CMDA conference, and I got a copy of your book, Tongue Ties. I love the subtitle, How a Tiny String Under the Tongue Impacts Nursing, Speech, Feeding, and More. So excited to bring this information to our viewers. Before we talk specifically about what tongue tie means, tell us a little bit about yourself and how you got involved in this work.
Yeah, so it all started with my own kids, right? I was finishing a pediatric residency up in Ohio and just had a couple weeks left, and we had our twins. So they were 38 weeks. My wife did a really good job keeping them in. I know this is OB podcast. And then, anyway, but 38 weeks, we were trying to deliver them naturally. And then baby A was head down, B was breech. And like the week before, our OB had a case where so the only thing worse than a C-section is having a vaginal and a C-section,
Right.
having both. And so that's what they had to do on this twin delivery the week before. So we opted for the C-section. But with Molly, 5 years later, we did get the V back. It was rough, but it was so bad I was sore the next day. It was 4 hours of pushing, and she was 42 weeks pregnant. So anyway, that was intense, but we got it. And so now all three healthy and happy, and the girls will be 10 in a couple of days. This is 10 years ago now this happened, and then Molly just turned 5 back in February. So we have 3 girls. I live in Birmingham. My wife's a nurse practitioner. She did acute care. She now stays home with them and homeschools and training them up. So
Great. So you said it's personal. So tell us what tongue tie is and what's your connection, how you first learned about it.
Yeah, so with the twins, we're having a lot of trouble nursing them. We had a lactation consultant out to our house 10 times. She says the most she'd ever been to anyone's house.
Wow.
And my wife was determined to breastfeed them, and then we couldn't figure out what was going on. So we saw our pediatrician who we loved, and she said, there's a tongue tie. So she clipped it, and we thought that was the answer, but then they still struggled after that. And then our lactation consultant said, no, see, they'd only got it halfway. So it's like a frenotomy, just like a clip or a snip. Go see this dentist who uses a laser, and he got it fully. So he got the whole thing. And so it's kind of like syndactyly, another, common birth defect where you have webbed fingers. And if you just cut it halfway, well, you wouldn't have full function of your hand. And so you have to actually separate out the tissue fully. In the mouth, it's kind of a dark hole. And so people don't realize, how far back it actually goes. And so after it was released, they did much better. One could nurse well, with the other one couldn't. And that was probably because we did Noelle's lip tie and her tongue tie. And for Hannah, we were trying to be conservative. We only did her tongue and not her lip. And she still had reflux, trouble latching on, all these issues. There's 2 of them. So my wife ended up pumping for a year with the girls. And then when Molly came, again, after the VBAC, very difficult delivery, as soon as she came out, I was really proud of myself. I waited 5 whole minutes before I told my wife she has a tongue tie, because it was like to the tip. like your first cry. So it's something that the OBs and midwives and whoever's listening can notice right away. I mean, it's the first cry. You can see it in a lot of these babies where the string of under the tongue is attached, close to the tip, maybe halfway back. And we'll get into it more about how to diagnose it. But
Yeah.
it's about 1 in 4 babies. And so, all the newborn screening stuff, like for hearing loss, is like 1 in 10,000. For SCID, severe combined immunodeficiency, is like 1 in 100,000, thankfully. But this is 1 in 4, and it's not routinely screened for at all in hospitals. In Brazil, it's a national law, but in the States, it's not. There's a couple countries it's a law, but anyway,
Okay.
so it's
So,
something definitely worth looking at.
yeah. So 1 in 4, 25% of
It's a
newborns.
lot of babies.
Yeah. So you've used the terms tongue tie and lip tie. Can you differentiate those and just define what is a tongue
Yeah,
tie?
yeah.
What is a lip tie?
There's cheek ties too. So it's kind of
Okay.
in total, they're called oral restrictions. Some people say tethered oral tissues. Tongue tie, ankyloglossia, there's like 30 different words for it, but basically the string under your tongue. It's in the Bible, Mark 7:35. The string of his tongue was released and he spoke plainly. It's in the earliest Japanese writings, in the Quran. King Louis the 13th was tongue tied. So all these, throughout history. So basically, it's a failure of apoptosis, just like with syndactyly on your hand. The tissue should recede and it doesn't.
Okay.
They're not really sure why. It's often genetic. It's often dad's fault, like most things are, right? Um, and then another thought is possibly excess folic acid. So it thickens up midline tissues, so you don't get spina bifida or heart defects, other midline defects. And so some people think, when they thickens up the tissue under the lip or the tongue, it could be from like a higher amount of folic acid than even recommended, because there's not really an upper limit on folic acid. But I'm not an OB, so I don't know exactly. That's one of the hypotheses.
Mm-hmm.
So anyway,
Yeah.
and then a lip tie is under your upper lip typically. It's the upper lip, but it's hard because at birth, like 94% of babies have a low inserting frenum, right? That piece of tissue under the lip. So it's hard to tell. So it's based on the symptoms more than the appearance. And the same is
Okay.
true with tongue ties. So if the tongue is held down maybe 25% of the way, most babies with that would probably feed asymptomatically, no problems, no nipple pain for mom, for example. But some babies will still have a terrible time latching on because for whatever reason, that amount of restriction is too tight for them. So that's why it really, at birth, like the OB perspective, it's hard. The ones that are to the tip or close to the tip, those ones could be picked up and treated, pretty quickly. They're in the hospital perhaps, or, but basically all moms should be told, hey, if you do have struggles with nursing, reach out to lactation consultants, and it could be a tongue restriction. It doesn't have to be to the tip. And so even just like a brochure, like going through the common symptoms, like colic, reflux, gassiness, spitting up, nipple pain, trouble latching on, but trouble with bottles as well. And so those are kind of the common symptoms. So if someone just had one of those, maybe it's not a tongue or lip tie. Some babies are gassy,
Yeah.
but if they're spitting up and gassy and colicky and trouble latching on, the preponderance of symptoms, it's likely something is up with their tongue or lip is too tight.
Yeah.
And so anyway.
So you've said a lot of really interesting things there. One is there's a genetic component, and both your twins, I don't know if your twins are identical or
The
fraternal.
fraternal. Yeah.
Okay, so they're sisters that happen to be born at the same time, and both
Yep.
of them have it.
They both had it.
That,
And Molly's is to the tip.
okay,
And we did
gotcha.
the L5 methylfolate, like the activated form of folic acid, with Molly. So I guess theoretically it worked better than we just did the normal folic acid with the girls. And so it's hard to know, but Molly's was to the tip.
Yeah.
And mine was like halfway originally. Mine's been treated since then. But I mean, I had one for
Okay.
30 years and didn't know it. So we have a lot of parents come in, have a pretty tight tongue tie and don't even realize it, but it can cause issues throughout their whole life, right? Babies through adults.
Yeah, yeah. I want to get to the adults, but let's stick with the kids first
Sure, sure.
because as OBGYNs, of course, we're seeing the women immediately after they deliver, but then we're following them
Yep.
postpartum, but also, for GYN care
Yeah.
and are often asking how their children are doing. So tell us when we deliver a baby, I know you talked about screening. We typically then the pediatricians take over.
Sure.
So how do these kids initially present newborn compared to as they're continuing to feed?
Yeah. So basically, a lot of the times it snowballs. So it starts out in the hospital, maybe some nipple pain, and then
Okay.
lactation comes by. Like you've got to keep going. It hurts. It's normal to hurt for the first 6 weeks.
Hmm.
Well, it depends what degree of pain, right? Like a little bit of
Right.
pain, like a 1 to 3 maybe out of 10 pain, that could be normal. But if it's like a 6 or 7, like toe curling pain every time the baby latches on, that's not normal. If mom's nipples are bleeding afterward, that's not normal, right? So there's things that are common, and then there's things that are normal. So what's interesting is often be like, oh, colic's normal, spitting up's normal, gassiness is normal. It's like, well, it's common, right? And it's not optimal to have a colicky baby. And so if there's something we can do to help those babies when it's low risk, compare it to like circumcision. I'm not sure what the percentage of boys, for example, that get circumcised, but it's fairly high in America.
It is.
And there's zero current benefit, like to newborn, and then a potential benefit later with UTIs, penile cancer, that kind of stuff. But and it takes about 10-15 minutes from what I understand. I've never performed any circumcisions. And there's people have to get them revised under general anesthesia later. So it's not without risk. It's done for a current reason, a functional reason, with current benefits, as well as continuing benefits in the future with speech, solid feeding, eating, sleeping, and breathing, and dental development. So there's lots of future benefits as well, even when it's performed in the newborn. So that's what I was hoping to come on this podcast, which thank you for inviting me, because that's the best time to treat it is the first week, first month. That's ideal. The longer you wait, the more issues the baby gets, the more compensations they get. And so they get more bad habits, essentially. And then you have to rehabilitate those with speech therapy, with feeding therapy, lactation support, that kind of stuff.
Well, one of the interesting pictures in your book was the baby who, when it latched on the nipple, couldn't really open its mouth very wide compared to pre and post
Yep. A
the
wider gape
procedure.
afterward.
Yeah. So tell us how are these babies diagnosed?
Yeah, so based on symptoms as well as the appearance. So you basically need both. And so if the mom's coming to you guys do y'all see them at 4 weeks or 2 weeks, or how often do y'all typically check them afterward?
It really depends whether she had a C-section, complications, but
Mm-hmm.
at minimum, it's going to be 6 to 8 weeks, but we
Yeah.
may not see them once they're discharged from the hospital for a few
Yeah.
months.
So, I mean, what's sad is like, not to like single anyone out, but like primary care providers often don't pick up on it.
Yeah, the
And so
pediatricians see them really quickly,
they
and the
see them
family
like a week
practice doctors.
later, 2 weeks
Mhm.
later. And so some do. And some pediatricians treat them, with the laser the same exact way I do. But in general, a lot of it used to be like negative referrals. They'd be like, "Oh, don't go see Dr. Baxter. He's a dentist."
Mhm.
And now we had 37 pediatricians refer to us last year because
Okay.
they see the benefit and they're seeing, oh, but this really does make a difference. And so, but they're kind of hard to diagnose sometimes because it doesn't have to be to the tip. If it's to the tip, most people will see that, check for it. Although we see some kids that are 3 months old, 3 years old, 30 years old, and it's to the tip and no one picked it up. So those do kind of, fall through the cracks sometimes too. But the harder ones to pick up, it's like 25% of the way there, right? It's not to the tip. But they have all the symptoms of a tongue tie. So this nipple pain, although it doesn't have to be. Sometimes really poor or slow weight gain, although it doesn't have to
Mhm.
be. Sometimes they're chunky. But in general, it's the shallow latch, hiccuping a lot, and excessive in utero hiccups. I think there's a connection there, which is interesting for you guys. They hiccup like multiple times a day in utero. Often the parents are just told it's practicing breathing, from what I understand. Again, I'm not an OB. And then they come out and they hiccup a lot too, right? After they're born. And then we treat the tongue and then it goes away. So the hypothesis is that the swallow is dysfunctional somehow. And so they're practicing swallowing around 20 weeks, from what I understand, in utero. Tongue tie happens around the 12th week in development. But they start swallowing, practicing sucking around 20 weeks. So even the babies that come out and they're 3 days old, they still have, 20 weeks and 3 days of bad habits.
True.
So it's interesting. But anyway, the shallow latch, gassiness, fussy, colicky, the parents are really struggling and can impact mom's mental health too. Because, their hormones drop. They're supposed to be replaced by oxytocin, the pair bond hormone from breastfeeding. But then if they're not able to latch on or it hurts every time, They feel like, okay, I didn't get the birth I wanted. The birth always doesn't go to plan, or most of the time doesn't. And they're like, well, at least I can feed the baby the way I want to, right? I want to breastfeed. I know breast is best, that kind of stuff. And then they're like, oh, I can't even do that right. And then this mom guilt. And so we check all the moms with the EPDS 10, the Edinburgh
Mm-hmm.
Postnatal Depression Scale. And a
Mm-hmm.
lot of times they're scoring 13, which puts them at a high risk. It basically says they have postpartum depression. Over 10 as a high risk. One mom last week scored a 23, so really high. And then the last question asked about thoughts of self-harm. And she even marked, sometimes thoughts of self-harm. And so a lot of these moms coming to see us are really on the struggle bus, as we like to say. And so if we can treat the baby and by treating the baby, help the dyad, the nursing dyad, it can make a huge difference for that first, the fourth trimester, so to speak.
Yeah.
And so we're seeing a lot of improvements. And then we check them a week later and with the EPDS 10 again, and almost always the numbers are down significantly to where like above 10 to below 10. So I don't have a study on it yet, but and it's not every patient, but basically taking a few rocks out of their backpack, so to speak, it makes it a lot easier for them. So.
Yeah, having 3 children myself and having nursed them, it is, you put a lot of weight on yourself in terms of being able to always tell women, God gave our breasts for our babies. They're going to usually work. We just have to figure out between the two of us how to make that happen. And it sounds like this is one of those things that can positively impact it, not only nursing, but later on, language and speech.
Yeah.
So tell me a little bit let's say I have a newborn that's been diagnosed and is having functional problems with eating. What would a parent expect if they came to see someone like you in terms of their treatment options?
Yeah, sure. So a lot of people come from 2 to 4 hours away is probably our average patient, although we've had patients from other countries even, and almost all 50 states. And so they come see us. We do the consult and the procedure, if indicated, the same day. We basically do an exam. So we'll do a full exam, check the lip, check for cheek ties or buccal ties, check under the tongue. Buccal ties is like 1 in 10 tongue-tied babies we treat buccals on. There's not a lot of good research on it. I know because I wrote the one article on it. But anyway, so we'll lift the lip up, check the cheeks for tightness, tension, check for feels like a speed bump. Under the tongue, you run your fingers side to side and check for tension. Lifting up with 2 fingers coming from behind. I have a headlamp on so I can see under the tongue. We'll take pictures of that. And then we'll also look at the symptom assessment sheet. So the symptom assessment sheet, it's 50-item questionnaire, goes over all the symptoms that kind of are we see improve afterward, like the hiccuping, stuff people don't even relate, like colic and gassiness and spitting up and taking forever to feed. They feel like they're always hungry, that kind of stuff. And then mom's issues like mastitis, plugged ducts, trouble with nursing on one side versus the other, obviously flattened, blanched, creased, lipstick-shaped nipples, nipple damage, that kind of stuff. And then pain, scale of 1 to 10. And so we'll look at all those items, and then we'll kind of put that together with what we see in the pictures, and then we'll come up with a plan. And so often that's releasing the same day. Most of the patients have already seen lactation. Almost all of them, they've failed lactation intervention. So it's not just like, oh, they just aren't latching them on properly, or it's just a positioning issue. There's something else going on. Or sometimes they'll come in, this is my 4th baby. I've nursed the other 3. Something's different with that one. Right. Most of the time it's a tongue tie issue. Sometimes like, oh, there's like all 3 of my other ones. They all, they just suck at nursing. They just can't do it. I guess they don't suck. They just can't do it. Right. And so, all those things, they're like telltale signs that something's not going well. Or we've switched to a bottle and they still can't do a bottle. We've been through 5 different bottles, 3 different formulas. We can't figure out. They're having to go on Alimentum, Nutramigen, NeoSure, all these things. Like those babies that are really struggling, often there is partly, could be a tongue or lip tie issue. And so then we, if we do need it, we offer to pray with all the patients beforehand. Sometimes they say no, but we always offer to pray with them first because, again, most of them are on the struggle bus, and they do appreciate that. And then we'll borrow the baby about 4 minutes. We use a CO2 laser. It just disappears. You can certainly do it with scissors as well. It's not just one cut, though, with scissors. It's typically 4 or 5 small cuts to get a lay flat diamond shape. On the tongue, it's more of a triangle or a teardrop shape. With scissors, obviously, it bleeds more, so it's harder to see all the fascia, the connective tissue. Make sure we remove all that, but still avoid the muscle, the genioglossus muscle, as well as avoiding lingual nerve, deep lingual vein, that kind of important structures. And so that's why you like the laser. It's ultra precise. It's kind of like LASIK, like using the laser. Um,
Right.
but it's so nice. It just disappears. It basically erases the tissue, minimal to no bleeding. They can go back to nurse with mom right away. We're not putting them to sleep. We don't put kids to sleep to do it. It takes 10 seconds. So it's really a nice procedure. And it's like 99% of the time it works. It's not always. Nothing is 100%, obviously. But if you do it right and with a team approach, so working with OBs and lactation and pediatricians and feeding therapists, chiropractors, PTs, kind of the whole team approach, then often it works very, very well. And then the hard part's the stretches afterward. So if you just cut it and then leave it, it's like if you got your ear pierced but didn't wear the earring, it'll close
Right.
back together. So you
Okay.
have to do some wound care afterward, like massages on it. For babies, is 3 times a day for 4 weeks, starting the day after the procedure. And so we have videos on our YouTube channel about how to do it. We show the parents how to do it, and then we follow up with everyone at 1 week. So if you leave any of those steps out, like you don't get the history right, you're not going to pick up on who has tongue ties or not. If you don't do the examination properly with gloves, lifting up, you take pictures so we can all see it and discuss. If you don't do the procedure right, the follow-up and the aftercare, if you skip any of those steps, it won't work as well as you want it to work.
Right. Okay, so I may have missed this, but as a mom, I'm thinking, is it going to hurt my baby? Is it painful?
Yeah.
Tell me about what you do to make the babies comfortable.
Yeah, we use 2% viscous lidocaine. So we do some numbing jelly first. We used to use EMLA, but I think the viscous lidocaine is a little bit safer. It doesn't have the prilocaine in it because there's a theoretical risk of methemoglobinemia.
Okay.
And so we've never seen that, obviously. But so 2% viscous lidocaine. You can also use like sweetums, like sugar water. We don't use that though. Like they use it for circumcisions.
Right.
But the baby goes back to breast right away. And if they haven't fed in like an hour or two, if they're hungry, they'll almost always latch on. And most of the time, mom says there's less pain, even from the initial latch. They can tell a difference. It's not just a placebo effect. There's 5 or 6 randomized control trials showing the benefits of tongue tie procedures for babies, for newborns. And even like a posterior tongue tie, it's like a less obvious tongue tie. It's not backed by the tonsils. It's in the same place under the tongue. But there's a randomized control trial with bottle feeding babies where they only treated the posterior tongue tie, same exact way we do with the CO2 laser. And they saw benefits with a special bottle that's used in NICUs. It has like a cantilever, so it gives a computerized readout. They have faster tongue speed, more coordinated, more rhythmic, more adaptable. Also less nipple pain for mom, also less reflux, also better self-efficacy scores for the breastfeeding self-efficacy score for moms. And so all that to say, there's good science backing it up, and it works most of the time. And again, nothing's 100% of the time, but we're happy to help out the moms that come see us. So
yeah, I in your book, you have an awful lot of the research studies that are out there. Given it seems like some awful good research. What are some of the barriers or misconceptions that are still out there related to tongue tie that you have to help families or even healthcare practitioners, the pediatricians, overcome to make that referral?
Yeah, often people think it has to be to the tip to cause a problem. And so that's one of the biggest ones. If they can stick their tongue out, they're fine. It's like, well, like it kind of comes a little bit out, but it should go most of the way down the chin. But that's the worst test. The best test is elevating or lifting up the tongue because that's the critical movement for nursing, bottle feeding, speech, eating, sleeping. Your tongue has to go up, not sticking out. That's like for playing a wind instrument, kissing, licking an ice cream cone, that kind of stuff is protrusion. But elevation is the key. Symptoms and function are more important than the appearance. So again, sometimes it's 10% of the way there. It's barely to the tip. It's just a little bit there. But for that individual baby, it might be causing a problem. So we're always looking at risk versus benefit and then individualized, precision medicine or dentistry. The stretches aren't needed. You have to do stretches or also stick back together. They often think a snip or a clip is sufficient. That's what happened to our girls, but it wasn't enough for them. And it might be for some babies. Some babies, a frenotomy or a snip or a clip is enough. And that's what's often done in the hospitals. But most babies, it's better to give them a full release because we don't know how tight is too tight for that individual baby. So if we just give everyone the most mobility possible, which then you have to do stretches afterward, that sets them up for a better long-term solution because We see some babies that were clipped as babies, and then they were able to feed okay. And then later on, they did get speech issues, speech delay, articulation issues, solid feeding issues. So those kids that are really slow eaters, they take like an hour to eat. They're distracted eaters, real picky eating. Often they have a restricted tongue. Speech delay, sleeping issues like teeth grinding, snoring, restless sleeping. Then they can get hyperactivity from that, behavior issues because they're not sleeping well. So those kids often have tongue ties. And most people listening are like, oh my gosh, that's Johnny. Like that could be my kid. He was terrible, a difficult baby, a colicky baby. Those ones probably have some kind of a tongue or lip tie. And they get bigger, and then they have all these kind of snowball. Again, it doesn't go away. It just kind of changes over time. So.
Yeah. Well, thank you so much for all this great information. So, one last question.
Yeah.
From a practical standpoint, insurance, parents are going to ask this to us as healthcare practitioners. Does my insurance cover this? Will insurance, is it usually dental insurance, your medical insurance, maybe both?
Yeah. So it's billed medically is the way we do it. We bill dental for a while, but babies don't have teeth, and it often gets denied because it's congenital anomaly. So it's from birth. So if it's done in the hospital, so like if they go to an ENT, for example, and they're affiliated with Children's Hospital, they'll often get a facility fee on there, and that could be several $1,000s, even if they didn't put the baby to sleep. And so it's out of pocket for us, but we give them a medical claim form to submit for a possible reimbursement. Most people get something back. It just varies. Some people get the whole thing back minus their copay. Other people get less, but we found that medical insurance is the best way to bill it. So that's what we do.
All right, so this is Dr. Baxter's book, Tongue Tied. What I love about the book, it says at the very beginning, is all the proceeds from the book will be donated to charity for work locally and in the most impoverished areas around the world. So thank you for your generosity. And this can be found on Amazon, right?
Yep. Amazon. We have a live course. We have an online course, Tongue Tied Academy, and all the money from the online course, our in-person course for providers, as well as the book, goes into one account. We donate the whole thing. And so happy to do mission towards Christian purposes, mission work, basically locally and globally. So.
Well, great. Well, thank you, Dr. Baxter, for joining us. And thank you to our listeners also for joining us today. If you like this episode, be sure to give us a like and subscribe on our YouTube channel, and give us a 5-star review if you're listening on a podcast app. And we will see you on our next episode. Have a great day, everyone.
Thanks, Doc.